Hi, good morning. Thank you for having me. So today we're going to follow up on Rick and Marta's talks to get and Joshua's talks to go more into detail about what we're seeing not only in the drug supply, what kind of drugs people are actually dying from in overdose. So as a way to start up, I work at the Opioid Data Lab, which is a multi-university collaboration between University of North Carolina, University of Kentucky, and the University of Florida. The studies at the Opioid Data Lab are divided into three categories: theory, practice, and lived experience. The theory studies are biostats, psychology, pharmacology, and epi methods. Applied research is really looking at the practice of medicine, pharmacy, and vital statistics. And then the lived experience studies are the most fun and interesting. They're initiated by people with lived experience and with their direct participation, and they're answering questions as science and service for community members. So we'll see kind of pieces of all three of these come together in this talk. So I'm going to divide up into three parts. So getting more specific into first overdose data themselves, then looking at the combination of prescribing plus overdose data, and then looking at the specifics of street drugs. So we're going to start with overdose data. So this research was funded by the U.S. Food and Drug Administration, and some of the folks in the room here today from the agency have been part of this work. So when we think about looking at exposure versus with cause and effect, exposure outcome, we have prescriptions dispensed and some kind of adverse event. So this is the basic framework. Here we're looking at prescriptions dispensed and overdose deaths. There are limitations to all of these data, and I'm going to say these up front so I don't have to keep saying them every single time, but just wanted to be clear. We're limited by what records and what is actually said on death certificates, even though we're trying to make more sense of it, even though we're drawing causal inferences and population level inferences, we are still limited by that. The causal emphasis can vary by medical examiner. So if some medical examiners see fentanyl as one of the substances listed, they may check the case out as being a fentanyl overdose death, whereas other medical examiners may include those other substances. So there is variation there. We don't really have much in the way of social antecedents and other kind of behavioral data. We can't distinguish intentional from accidental polysubstance use. So did the person know they were ingesting more than one substance? And dispensing records can't capture street drug exposure, but we can capture that in other ways. And finally, a general limitation in previous studies has been that we can't tell if people left the population or died of other causes. The statistical methods we use and the data sources we have in Kentucky allow us to at least address that question, which is a limitation of some of the other studies. So all the limitations aside, now we're going to talk about, at the end of the day, I still feel that these data can be insightful. As we've seen in every single presentation today, these data are being displayed and inferences are being drawn from them. So let's do a better job at measuring some of these things that are driving our idea of what's going on. So I'll just acknowledge this has been a huge effort led by the University of Kentucky, Svetla and then Jana Makinich and her team at FDA as well. So thank you to all. Okay, so the first thing is humans are smart, machines are stupid, all right? Is this a polysubstance overdose death? Would you call this a polysubstance overdose death? Yes, right? Yes. But did you notice that it says acetyl fentanyl? The L is missing, right? In acetyl. It doesn't say overdose, it says intoxication. And then we have a description that's self-ingestion of drugs. All of this together using existing systems would not necessarily call this a polysubstance overdose because of the way that the variation that there is in the way death certificates are written. But we know as humans, so let's get the machines to catch up with us. There's two tools that have been developed, one by CSTE and one by, it was FDA at the time, James Trinidad, to take the literal text on death certificates and identify which substances were involved. And what we wanted to do, and if you look, these are 2016 publications. So the technology that was being used was really like a decade old at this point. And this was an important first step. We wanted to refresh this with modern tools, working with some of the same folks who were involved in the original effort, like Holly Herdegard, and trying to kind of bring this to the fore, but also at the same time to look at how we think about polysubstance overdoses and how we classify them. So the new tool is up and available now. The QR code is here if you want to grab that. And let's look at, and I won't go into the full details of all the methods, but they're documented there in very great detail. But let's go and see kind of what this does to change our ideas of what's going on. So here's an audience participation. What % of overdose deaths are single substance? And we're looking at data from Kentucky from 21 to 23. So the options are 10, 15, 20, or 25%. Just shout it out. And if you could tell me what you see on the chat, that would be great. 15, 10. Reported. This is from the data. In the data, what do you think? So we heard 10 and 15 in the room. 20. Okay. Anybody higher? Higher? What does it look like in the chat? 20. Okay. Well, we are about 15% over the different years using our revised methodology. So congratulations to all the 15%ers. So I think this is an important starting point. The numbers, and so this kind of gives you kind of just looking at it in more detail. But fentanyl, a single substance fentanyl overdose deaths is only about 4%, 4 or 5%. Usually we're seeing other things there too. Okay. So kind of taking those tools and applying them into this framework of exposure of prescription opioids and overdose death, right? Kind of the big question that has driven a lot of research over the last 20 years. So this is also work that has been funded by the FDA. So what's not obvious in a lot of that research is that most studies that are looking at the association between prescription opioid dispensing and overdose mortality don't match on the specific substance. This is a little hard to believe, but if you look back, you'll see this is the case. So what we were able to do using this methodology that I just described is for the first time getting specific into this is the drug the patient was, or the individual was prescribed, and this is the substance that appeared in their medical toxicology after an overdose event, right? This should be the strongest causal link to what we think when we think of in terms of patient safety. So this is something that has been published, and you can see the full paper there, the citations there. So here's the next audience participation question. What is the average length of time between the last opioid prescription and the overdose death on that specific substance? So please put it into the chat and shout it out in the room. Your choices are less than 90 days, 8 months, 1.5 years, and 3.5 years. 8 months. 1.5. What else do we hear? What's that? Less than 90 days. What do we hear in the chat? Less than 90 days. Y'all all are wrong. Sorry. It's 3.5 years. 3.5 years between the date of the last prescription and the overdose death from that substance. So this, I think, really challenges our ideas of patient safety with these medications, right? And I can't believe it took us 20 years of being in this field to get to this drug-specific level of information, right? So that's 1,400 days to intervene. 1,400 days where we could have done something to help and prevent that overdose from happening, right? And I think these are the two questions as a public health practitioner that I think of, which is what happens between that last prescription and overdose? What are the behaviors? What do those days look like for those individuals? And then from the intervention side, what should we be doing in that 1,400 days to prevent these overdose deaths? I don't have the answers, but I welcome hearing what the audience thinks in the chat. So this kind of led us to a deeper conversation about what are the causal pathways between prescription opioid exposure and overdose death. And these are the 5 that we came up with, and trying to summarize, really the last 20 years of conversation about this topic. So is it patient behavior, taking more than prescribed? We've all heard these theories, right? But just spelling this out. Is it short-term toxicity? So too high a starting dose, or benzodiazepines plus opioids causing some sort of toxicity. These are all things that we believe and that we hear about in the media or in just general conversation. But when we're thinking about 1,400 days, these short-term toxicity issues don't seem to be what's driving the volume of the overdose deaths. We think of another pathway, number 3, long-term iatrogenic exposure leading to opioid use disorder, and then illicit exposure. So that's another potential pathway, and that's definitely within the realm of possibilities from our data. We also hear abrupt tapering of long-term opioid patients who have been stable, and then their deaths can be suicide or overdose based on what they're able to find on the street and what kind of care they're able to receive. And then pre-existing mental health conditions, then getting an iatrogenic exposure, leading to opioid use disorder and then overdose death. So these are all pathways. Our data are suggesting more 3, 4, 3 and 5 are probably more likely in this causal framework, but we didn't intend for that to be a causal paper, but just a way to start the conversation. Okay, so what's actually in street drugs? So this is work that's funded by the North Carolina General Assembly as well as 2 private foundations. So the short answer to this is going to be everything is polysubstance use except for methamphetamine and crack. We're at this amazingly different point in our history of substances in the United States where methamphetamine and crack, which were like the kind of scariest drugs, right? The panic drugs 20 years ago are now the ones that are least adulterated. Everything else is actually much worse off. So we know that street drugs change constantly, and we're still losing too many people we love. But we don't find out what's in street drugs until it's too late, when people are either dead or they're arrested. There's no opportunity for prevention. There's no opportunity for recovery. So at UNC, we test street drugs to figure out what's actually in them. It's a public service of a public university. We do this using these kits, which are coming around, and harm reduction programs, health departments, clinics, hospitals, EMS teams, drug user unions send us samples from around the country. We can accept samples as a couple scoops of powder, the swab of an empty baggie, a fragment of a pill, or a used cotton. So pretty flexible. This is what it looks like in practice. This is Ainsley Bryce out at Holler Harm Reduction in Western Appalachian, North Carolina. The samples are given to us voluntarily, and the tests are anonymous. The results are anonymously available. We collect some little pieces, some data, which you can see in the card in the kit, but molecules don't tell the complete story, so we try to get more information on sensations and overdose circumstances. All right, now I'm going, okay. Okay, the packages arrive on our campus via FedEx, and yes, we are in compliance with all federal and DEA laws around this, and we have the licenses to do this. So this is our paradigm. We record the information, catalog the samples. We use untargeted search using mass spec, GCMS, and figure out what's actually in the drug samples. So that gives you a sense of what it looks like on a day-to-day basis. So as of yesterday, we've tested about 7,200 drug samples from 37 states and 142 public health programs. We've detected 326 different substances in the drug supply, which when we talk to our Canadian colleagues who have done this for longer, they kind of laugh at us and you're like, okay, young children, because they see like 800, their numbers are like up at 800 or 1,000 because they've been doing it for a decade. So when we provide the results back to individuals using a QR code, and people can get the results online. So the way we've framed this is to empower people to answer questions of local relevance. And so some of the questions that the programs use have been answering on their own is there fentanyl in the black tar? Are nitazines causing the overdoses that they're seeing in their local area? What killed my husband is a surprisingly common reason why people seek out our service, because autopsies take 8 months or a year to get results and people want closure. So there's all these different questions that local harm reduction groups and public health departments are able to answer with our test strips. So not with our test strips, with our test kits. So here's an example from Asheboro in Central North Carolina. This is 16 substances in something that was supposed to be heroin. And so it's a mix of medicines, human medicines, veterinary medicines, numbing agents, stimulants, things of synthetic and organic origin, as well as production byproducts and bulking agents. So this is not a particularly surprising example, but it's not all this bad, but it kind of gives you an example of the breadth of what we see in there. So kind of linking to this afternoon's topics of psychedelics, I'm going to show you one example that we have been tracking. So are people familiar with 2-fluoro-2-oxo-PCE? Probably not. Well, thank you. Yes, you are. The one psychedelic doctor in the room or clinician knows it, but you may recognize it by its other name or probably not. The short of it is this is a dissociative anesthetic that has similar properties to ketamine, or in the broad family of more potent ketamine analogs. So if you could roll the tape, that'd be great. Thank you. We're going to hear from Dalton Barrett, who is one of the EMS leaders in Tarboro, North Carolina, which is in the eastern part of the country, of the state. Think tobacco and hogs. It's a rural place. So thanks. Go for it.
Families, community members, and law enforcement have been searching for answers about what caused these deaths. Tonight, WRAL investigative data journalist Ali Ingersoll has new details about what was in the contaminated supply.
What was sold as illegal fentanyl wound up being a mixture of 8 different drugs.
It was a particularly nasty mix of substances that involved fentanyl and xylazine, but also a very potent benzodiazepine, a hallucinogen, and another kind of designer chemical.
That's Dr. Nabarun Dasgupta, a senior scientist at the UNC Street Drug Analysis Lab. They have a partnership with dozens of public health organizations, including Edgecombe EMS.
This was pretty eye-opening for sure for us. When I saw the results, there was a number of things that I'd never seen before in Edgecombe County per se, and it didn't really make sense as far as the mixture.
This is their second attempt at trying to identify what was in the supply. This time, the sample came from a bag stamped with a certain design. What's particularly unsettling, a few months earlier, Barrett had samples tested from a different bag with the same stamp, and the results came back vastly different.
Usually we try and think about these stamps as like labels on a beer bottle, like this is Michelob Ultra, this is this, and it's like the same thing time and time again. But that's not the case.
Barrett says he will now take this information to the community, hopeful that knowing a mix like this exists will raise awareness and save lives.
Seeing people of my age dying from something that we can prevent really kind of tickles my heartstrings as a medical professional.
For WRAL News, I'm Ali Ingersoll.
With the variety of drugs in the supply, Ali wanted to know, would naloxone have worked to reverse that overdose? Both men said yes, but they probably would have remained unconscious just because of how potent that substance was.
So I know we dog on news media sometimes, but that's a pretty good piece of reporting, right? And I think it ties together a lot of the things that we have seen. So now we've been in Tarboro, eastern North Carolina, rural community. Let's zoom out and let's look at those samples. So these are the batches they had sent, and it was the green Pringles that was the one that contained the 2-fluoro-2-oxo-PCE. What else was in there? So there was bromazolam, xylazine, fentanyl, also, and teletamine in here, right? So this is like a pretty nasty combination of things that was very unexpected, and it was green, which was not super unusual, but caught our attention, right? The date on this sample collected was May 10th. So zooming out to the East Coast now, let's look at a sample that we received that was collected on May 9th from upstate New York, from Johnson City, and New York, not Tennessee, New York. And look, it's pretty much the same mix, right? And it was also green. And so we were like, okay, what's going on? This was one of the first times that we had seen 2-fluoro-2-oxo-PCE mixed in with fentanyl unexpectedly. Well, we zoom out, and what is 2-fluoro-2-oxo-PCE? It turns out that kind of now zooming from the United States into the global kind of picture, is something that was used, that was combined with ketamine or used as a substitute for ketamine in the club drug scene in Canberra, Australia, and had its origins detected, origins kind of where it was originally detected in Hong Kong about 5 years before that. So we have something that's showing up on the same day, more or less, in eastern North Carolina, in upstate New York, that has, when it's used in that club drug context in other countries, is something that is a kind of more psychedelic, recreational, younger population, party scene. But now, having it arrive in the US mixed with fentanyl and being sold as a street drug. So those individuals, what was interesting too is when we spoke with the hospital, they, in their blood tests, they were misidentifying, getting false positives for it being ketamine. And it wasn't ketamine, but that's how it was reacting in their assays. So I think this kind of encapsulates the connection between harm reduction drug checking, connecting it back to overdose, connecting it back to the global supply, and at the same time, kind of understanding how this all fits together. I'll skip this other example, but in the interest of time, but here you can sign up for our newsletter, and all our data are public and published daily and pushed daily, so feel free to look at those results, and I'm happy to take questions. Thank you.